Good morning, everyone, and welcome to today's meeting. I would like to welcome you all here today. For those who don't know me, my name is Khaled El Sayad. I'm a radiation oncologist in Germany, and I am chairman of German-Egyptian Social and Scientific Relationships Organization. I would like to introduce our guest today, Professor Dr. Nieschlag. Professor Nieschlag graduated from University of Bonn and was trained in London and Edinburgh. In 1975, he was appointed as a professor in field of internal medicine, and between 1976 and 1986, he was the head of experimental endocrinology department at University Hospital in Munster. From 1980 and 1988, he was the head of reproductive medicine research group of Max Planck Institute in Munster, and from 1986 and 2007, he was appointed as the director of reproductive medicine department at University Hospital Munster. He was president of numerous organizations such as International Society for Andrology and German Society of Endocrinology, European Academy Andrology, and president of German Society of Andrology. In addition, he was also the president of the German Society of Reproductive Medicine and chairman of WHO Task Force for Male Fertility. Since 2007, he has been appointed as the president of European Society of Endocrinology. Professor Nieschlag is the editor of 9 books and has authored more than 250 articles in books and more than 800 articles published in biomedical scientific journals. Ja. Noch aktuell oder? So, oder haben Sie mehr?
Ja. Ziemlich aktuell.
Okay. Since January 2021, GESR organization is honored to have Professor Nieschlag as a member of our organization. Professor Nieschlag, please proceed with your presentation.
I'm very happy that this society, the German-Egyptian Social and Scientific Relationships, was founded. And I congratulate Khaled that he succeeded in producing this society. And I am grateful for your introduction, which was very acute. And my topic today is testosterone substitution: for whom, when, and how. And first of all, I would like to point out that there are several that the testes, which are the content of my talk today, have a dual function, as everybody knows: production of testosterone and spermatogenesis, production of sperm. And if one of these functions or both are defect, then we call it hypogonadism. And the symptoms are androgen deficiency, related infertility, and comorbidities. They all can cause hypogonadism. Okay. There are several guidelines. In the first one, I was also involved, which was from 2008, from the various societies, specifically in late onset hypogonadism. And then later, there came more societies with guidelines, including the Endocrine Society of the US. And I will talk about the definition and diagnosis of hypogonadism, I will talk about testosterone substitution and how we should monitor testosterone substitution. The famous 7 trials I will mention, and you will hear that later on. The obesity, metabolic syndrome, and diabetes I will touch as causes of hypogonadism. And finally, prostate carcinoma, I will briefly touch. So, testosterone has many target organs. Almost all organs and tissues have testosterone receptors. And here you see the brain functions. You see that the heart is protected by testosterone. The male sexual organs, of course, depend on the testosterone. The skin, the hair growth, the balding are all results of testosterone. And the larynx also is dependent on testosterone. And the muscles, most important in sports, but also for normal people, have androgen receptors. The liver for protein synthesis, the bone marrow for stimulating stem cells, especially for the red blood, and finally the bones. They accelerate the linear growth and the closure of the epiphysis, and the bone mass is increased by testosterone. So this multitude of symptoms or of functions causes many symptoms. And it is useful to divide the symptoms, whether the hypogonadism starts before or after completed puberty, because those boys who don't get into puberty, they stay more or less as children. Whereas when the puberty was completed, then the symptoms are different, because they were, first of all, they had testosterone action during the puberty, and therefore the symptoms are slightly different. And if we go further, then we classify the hypogonadism in primary and secondary and functional hypogonadism. These are the 3 categories. And if we start with the classification of primary hypogonadism, then you see the leading symptom or the leading disease is Klinefelter syndrome. And then there are different anarchias causing hypogonadism by trauma or torsion or tumor. The mal-descended testes may be dysfunct. Orchitis can result in testicular atrophy. Radiation therapy, as we have heard in the previous lecture, can cause infertility and even lack of testosterone. And finally, there are some disorders of testosterone synthesis resulting in DSDs, diseases. And if we show at the most important syndrome, the Klinefelter syndrome, it has a high incidence of 1 man in 500, and it is caused by non-destruction of the XXY syndrome. And there are small testes as a characteristicum. They are very small, and azoospermia results in most cases, and gynecomastia and other symptoms are the consequence of the Klinefelter syndrome, and they always need testosterone. When we then come to the secondary hypogonadism, then we see that the congenital hypogonadotropic hypogonadism and Kallmann syndrome, which is associated with the anosmia, is the leading symptom, but much less frequent than the Klinefelter syndrome. And also there may be brain traumas, even from football, playing. There may be pituitary tumors. There may be pituitary infections, and hemochromatosis can also affect the pituitary. And then is a multiple pituitary hormone deficiency. And finally, hyperprolactinemia. And here you see a Kallmann patient who came only to the diagnosis as 33 years. And you see that he has hardly reached puberty. So, and he is 33 years old at the diagnosis, and that is very, very late and should not happen, because he was very unhappy and depressed about his condition. And you will see later how testosterone can change him. And then there is the late onset hypogonadism, which is still slightly controversial, because some people think that it is only a functional hypogonadism following from diabetes and other diseases, obesity and so on. And others think that it is a real disease. And we arrived at the definition that there may be less than 3% of the older men who have not a functional hypogonadism, but a real endogenous hypogonadism. And yet now we come to functional hypogonadism, like extreme obesity, the metabolic syndrome, and diabetes. They all can cause hypogonadism. And chronic systemic diseases like malignancies, liver cirrhosis, diabetes, and Crohn's disease can all cause hypogonadism. And medications which we prescribe in the daily practice, like antihypertensive drugs, antidepressants, and medications induced by hyperprolactinemia, then like metoclopramide, and anabolic steroids are often overlooked in the origin of the hypogonadism, because people are very secretly about the use of anabolic steroids, and they don't want to talk about it, and they don't give it as a reason for the hypogonadism. And finally, in prostate carcinoma, there may also be castrated or chemotherapy or radiation can cause also hypogonadism. And overtraining by sports and eating disorders can also cause a hypogonadism, which then is male athletes triad called. And the anabolic steroid deprivation syndrome is when the patient wants to stop testosterone and under anabolic steroids, then they may come in a hypogonadism, because these substances, the anabolic steroids, remain very long in the body. So the symptoms of late onset hypogonadism, if we come back to this disease, you see here that the loss of libido, erectile dysfunction, decreased vitality, and many other symptoms are consequences of the aging male and may cause hypogonadism. But as I said, there are also indications that is a basic hypogonadism, which comes from combined pituitary and primary hypogonadism. And you see here that the testosterone therapy from the Endocrine Society guideline includes age as a organic cause and not as a functional cause. So we come back to this problem. And now you may ask, when the symptoms are there of testosterone deficiency, when the patient should be considered hypogonadal. And for a long time, there was a discussion where the lower limit of testosterone is. And you see in our first guideline, we set 8 to 12 because we couldn't find the Endocrine Society now says 9 to 10. And the recent guidelines from the International Consultation on Sexual Medicine, from the European Academy of Andrology, and from the European Association of Urology, they all consider 12 nanomoles as the lower limit of testosterone. So if we have combined symptoms and lower testosterone than 12 nanomoles, we can call that hypogonadism. And the things are slightly complicated and explain why there was a controversy about the lower limit of testosterone, because the different symptoms have different thresholds. And you see here, even below 15 nanomoles, it may already loss of vigor and loss of libido. Obesity starts below 12, feeling depressed, looking for lacking concentration, and diabetes may only start at below 10 nanomoles. And hot flushes and erectile dysfunction may start after below 8 nanomoles. So this is an interesting phenomenon that different symptoms have different thresholds. And you have to keep that in mind when you declare hypogonadism for your patient. So testosterone was first synthesized and identified for in 1935. And then the inventors of Butenandt and Rutschika, who simultaneously more or less synthesized testosterone independently, but from the synthesized, I mean, they had prescriptions how to synthesize testosterone, and that was published in 1935. So many people think that they got the Nobel Prize in 1939 because they invented testosterone, but that is not true. Butenandt got the Nobel Prize in 1939 for estrogens. So the contrary of testosterone. And Rutschika became the Nobel Prize for something completely different. He had synthesized fragrances and so perfumes, and so he did also not get the Nobel Prize for testosterone, although we think they should have deserved it. And today we have, since many years, testosterone preparations for routine use in the clinical. And here you see intramuscular. They are the oldest, and since 1952 we have testosterone nunthate, which comes in packages, and it is still a popular substance for testosterone substitution, although since the beginning of this century, we have testosterone decanoate, which is a really deep preparation. In the US, it was only granted in 2014, but it's also there. And I will show the kinetics and the advantages of this preparation in a short time. And then there is oral testosterone, Andrology called, which is also testosterone undecanoate as the injection, but it can be used orally because it is not absorbed by the blood, but by the lymph, and can therefore avoid the liver, deactivation capacity for testosterone. And in 2019, it came also on the US market. And finally, which is most popular now, is transdermal testosterone, because there are many preparations, as you see, and they are easy to apply. And I would say testosterone libido is mainly for younger men, and testosterone gels are mainly for older men. And now we look at the kinetics of testosterone enanthate here, and of testosterone undecanoate. And you see here that if you give it every 3 weeks, which is the standard time, then you get ups and downs and the patient feels that. Whereas with testosterone undecanoate, you get for 12 weeks slow and physiological concentration in the blood. That is a great advantage. And here you see over 10 years, many patients which we have collected, and primary and secondary and functional hypogonadism, and they all have very smooth levels in the physiological range. The gels, and I show one of our studies here, you see that when the gel is applied to the armpits or to the breast skin, then you get normal values from the low testosterone in the hypogonadal range. And then if you apply it daily, you get very smooth values. I show you here a curiosity, because the scrotal skin is very absorbent for testosterone. And when you use 5 grams for the 5 grams of gel, then you need only 1 gram when you apply to the scrotum. But it is not allowed, not licensed for that use. So it's a secret. And everybody can use it as he wants. So I show you the patient we had before with 33 years. When we treated him for 1.5 years, he started to look like a man with a beard and so on. And if you look at his whole body, you see that even the penis grow, and the hair is now very masculine. And these are the effects of testosterone. But you should remember that the various symptoms disappear slowly, as you can see on this spiral. The first is the effect on libido, and then comes on general activity. then the depressions go, and then the hematocrit increases after about 3 months. And so it is important to know that all effects do not come at the same moment. Now, it is important that you not only prescribe testosterone, but that you also survey the treatment. And you see here that the well-being is an important parameter, and the vigor and the mood and libido as sexual activity. And of the laboratory parameters, it is most important the serum testosterone at the end of an interval to measure, and the erythrocytes and hemoglobin, the hematocrit, has to be controlled, because if you give too much testosterone, then you run the risk that the hematocrit increases beyond the in the pathological range, and the consequences can be stroke and thrombosis. So this is very important. Also, the PSA, the prostate-specific antigen, is very important to measure. And bone density, every 2 years, you should, a patient on testosterone, give the bone density measurements. And then we have also contraindications for testosterone, which are important to know. And there is the prostate carcinoma and the mammary carcinoma, which is in 1% of the cases male mammary carcinoma. And the hematocrit should not be on 54. Then you should not start a testosterone therapy. And severe cardiac insufficiency is also a contraindication. When the patient wants to be father, when he wants to create a child, then testosterone is not a good recommendation, because it suppresses spermatogenesis. And without prescription, one should not, without a diagnosis of hypogonadism, one should never prescribe testosterone. And then we come to an affair in the United States, because there was a rush on testosterone, and there were, in the 1940s, here you see from the American Scientific Journal, from the Scientific American, you see that there were many clinics who prescribed testosterone without reason, without investigation, and therefore there was a rush in America for real studies, in particular in older men. And there we come to the 7 famous trials. And you see here that these 7 trials were directed to the physical function, for the sexual function, for vitality, for cognitive functions, for anemia and cardiovascular diseases, and bone trial was also in men over 65 years. And you see here the results. There was an increase in walking distance in those who had been treated for 1 year. There was an increase in libido and sexual function. There was an increase in hemoglobin, in unexplained anemias, and there was an increase in the bone mass of the lumbar and spine, of the lumbar spine and the hip. And there was no increase in fatigue and no improvement in delayed. Okay. And therefore, the American Society of Endocrinology declared that the testosterone had benefits for the older patients if they had symptoms and if they had low testosterone. So this is then clarified. And now we come to specific functional hypogonadism, like the metabolic syndrome. And you see here the definition of the metabolic syndrome. Everybody knows that. And the definitions of blood pressure and fasting glucose and so on. And here you see an example of metabolic syndrome. And the best is if the patient loses weight. And here you see this, how the testosterone increases with a loss of weight. And here you see that the diet and exercise help, but both the bariatric surgery can help to lose weight and to increase testosterone again. And here you see 650 hypogonadal men who have you seen before about how they lose weight over long periods. And so testosterone is beneficial for losing weight if he has a deficiency, if the patient has a deficiency. And also in pre-diabetes, it may have very good function. Here you see the patients who got testosterone, and here you see the patients who did not get testosterone. And here you see that the glucose did increase in the non-treated patients, and in the treated patients it became lower. And HbA1c also increased in the patients and in the non-treated patients, and was lower in the treated patient. And here is another example from a study in England where they had also diabetes type 2 patients grouped in testosterone treatment or non-treatment. And you see that those with low testosterone and not substitution had the highest death rate, morbidity, lethality. And those who were above 12 nanomole, they also had a higher life expectancy, and the best were those who had low testosterone and were substituted with testosterone. Now we come to the prostate, and the urologists always warned for testosterone, especially in older men, because it could cause prostate carcinoma. And here you see a very talking study from 600 untreated and 398 testosterone-treated patients, and you see that the prostate carcinoma rate is more or less the same in all patients treated or not treated. And meanwhile, there are several studies showing that other studies showing that testosterone does not cause prostate carcinoma. And in between, the urologists have started to treat testosterone in curative healed patients from suffering from hypogonadism because of the previous treatment. And this is in average 1 to 1.5 years after the curative treatment was finished. So we come to the conclusion, and the diagnosis of hypogonadism is very important. So there must be testosterone deficiency or comorbidities plus low testosterone. That is the prerequisite to diagnose hypogonadism. And intramuscular transdermal oral preparations are available for substitution there, so you can decide, your patient can decide what he prefers, and after a trial phase. And regular monitoring is also very important in the beginning at 3, 6, and 12 months. And when they have a year, then you have to continue in at least annual intervals. And the most important parameter of the blood is hematocrit, which should not be over 54. And PSA, of course, is also to be measured. Substitution has positive effects on anemia, osteoporosis, obesity, metabolic syndrome, diabetes type 2, erectile dysfunction. That is very important. And after a disease-free year, patients with prostate carcinoma can receive again testosterone. So we come to the conclusion, and my sentence is for the conclusion that testosterone substitution is for all men with properly diagnosed hypogonadism. That is very important. So I thank you for listening to my bubble talk. Okay, thank you very much.